آه، مساء الخير. بشكر حضراتكم جدا. إن يوم الجمعة الصبح أنتوا حريصين تتواجدوا. سعيد أكون معاكم. كل الشكر لبورد الاي اس دي دكتور ايناس شلتوت والبورد كله على الدعوة الكريمة. It's my pleasure to introduce Professor Rayaz Malik from United Kingdom. He's gonna talk about diabetic microvascular complications, diagnosis and management. Professor Malik.
Assalamu alaikum, everybody. I'd like to thank Professor Inas Shaltut and the organizing committee for asking me to speak on the topic of diabetic triopathy. So, what is the diabetic triopathy? This is, of course, retinopathy, nephropathy, and neuropathy. And as you can see, there is an order there. And most people start with retinopathy, then neuropathy, and they forget about neuropathy. I'm going to turn it on its head. And I'm going to first talk about neuropathy, which I believe is the most important of the microvascular complications. And then I will speak about retinopathy and finally nephropathy. So where do we start with diabetic neuropathy? I think we have lots of data from the UK, the US about the risk factors for diabetic neuropathy, but what we need are relevant studies from this region. And we have one particular study that we did in the Gulf region, which included data from Qatar, Saudi Arabia, Kuwait, where we looked at the risk factors that drive diabetic peripheral neuropathy. And what did we show? Well, actually, really, the traditional risk factors like poor glycemic control, hyperlipidemia, hypertension, obesity, less physical activity, smoking cigarettes. These are all risk factors for both diabetic peripheral neuropathy and painful diabetic neuropathy. So if you accept those as risk factors, then we ought to see what is the evidence out there that improving these risk factors has an impact on neuropathy. So if you look, first of all, at poor glycemic control, we have done studies actually with basal bolus insulin or with GLP-1 once weekly, exenatide, then with pioglitazone in poorly controlled type 2 diabetic patients in Qatar. What we did is randomize the patients to either basal bolus or exenatide with pioglitazone. In both arms, whether it was the combination of exenatide with pioglitazone or with basal bolus insulin, you can see HbA1c started at 10.5%, and in both arms it came down to around 7%. We then looked at whether or not there was evidence of nerve repair in these patients using the technique of corneal confocal microscopy, where we image nerve fibers, small nerve fibers, and see if there's evidence of regeneration. And what we showed is very clearly that all three measures of corneal nerve fiber regeneration improved in both arms. So in type 2 diabetes, improving glycemic control by about 3% does repair nerve fibers. We then, if we move to obesity, obesity is a risk factor and less physical activity is another risk factor. We now have data from patients with type 2 diabetes, again in Qatar, treated with semaglutide. What we show is, as one would expect, that there is going to be an impact on weight. So over 6 months, there was a progressive reduction in weight of about just over 10 kilograms. HbA1c improved, actually from a starting point of 6.5% down to 5.5%, and triglycerides also improved. Now, what happened to neuropathy? Well, actually, the DM4, which is a score of painful neuropathy, improved, but corneal nerves also improved. So corneal nerve fiber density and corneal nerve fiber length increased at 3 months and 6 months, although this was not significant. Branch density was. So branch density is a very sensitive marker of nerve regeneration. What we show very clearly is at 3 months and 6 months, there was a significant improvement in nerve branching. In addition to this, we've just finished a study, actually this is with collaborators from India, where we looked at the effects of dapagliflozin, the SGLT2 inhibitor. This is a small but well-conducted study in type 2 diabetes patients with diabetic neuropathy, randomized to either dapagliflozin 10 milligrams or standard of care. In both arms, there was a reduction in HbA1c by around 0.5%. Skin biopsy was undertaken, and what you see here is that there is actually, within 6 months, an increase in the number of small intraepidermal nerve fibers in the skin, both in the dapagliflozin arm, but also in the standard of care arm. And the standard of care arm was just traditional standard therapy like sulfonylureas, like glitazones. In CCM, however, we found that corneal nerve fiber density improved significantly in the dapagliflozin arm, not in the standard of care arm. Corneal nerve branch density improved in both, but again, was significantly increased in those on dapagliflozin, as was corneal nerve fiber length. So overall, it appears that dapagliflozin, an SGLT2 inhibitor, is inducing small nerve fiber regeneration. If we then move to hypertension, hypertension wasn't significant in this study, I must say, but was nevertheless a risk factor for diabetic neuropathy. And of course, many years ago, almost 20 years ago, we did a study looking at people with type 1 diabetes and type 2 diabetes who had a very poor HbA1c at that time, 10.1%, but blood pressure was pretty normal, 138/76. They had no microalbuminuria. We randomized them to either receive the ACE inhibitor trandalapril or placebo. And what we showed is actually it didn't really have much of an impact over 12 months on symptoms, on clinical deficits, on vibration perception, on autonomic function. However, when we looked at nerve conductions, there was an improvement in motor nerve conduction, M wave amplitude, and F wave latency, suggesting that ACE inhibitor treatment may improve diabetic neuropathy. Subsequently, from Italy, there was the DEMAND study, which took type 2 diabetic patients with admittedly elevated blood pressure, and however, a very good HbA1c of 6.3%. So this is really looking at the impact of lowering blood pressure. And what they did is they randomized to either receive ACE inhibitor, which was delapril, a combination of a calcium channel blocker and an ACE inhibitor, manidipine and delapril, or placebo. And what they showed when they looked at neuropathy using total neuropathy score, symptoms, signs, vibration perception, nerve conduction, and the composite, that actually in both the combination arm, manidipine plus delapril, and the delapril alone arm, there was actually a significant reduction in the overall prevalence of diabetic neuropathy, as measured by the measures that I've just stated, by almost 70%. And even new onset of neuropathy, that is the development of neuropathy, was reduced again by about 70%. And in fact, people who already had diabetic neuropathy in this trial, there was a regression. That is, there was an improvement in the neuropathy score by almost 500%. If we then look at hyperlipidemia, this is a risk factor, but which aspect of hyperlipidemia? Is it the cholesterol? Is it the triglycerides? Well, it would appear that actually it is a triglycerides. And this is a study not in type 2 diabetes, but in type 1 diabetes from Australia, which randomized people to oral omega-3 or placebo. And they assessed MNSI, QSART, perineal tibial sural nerve conduction, median nerve excitability. But to their surprise, they found actually no change in these. However, they measured corneal nerve integrity using corneal confocal microscopy and were able to show over 180 days there was a significant increase in corneal nerve fiber length, but also in nerve fiber density and branch density. So again, the message is that omega-3 in these patients was repairing, regenerating nerves. We now have data actually almost 14 years ago. There was a study called the FIELD study, which actually showed that there was less amputation in people randomized to fenofibrate as opposed to placebo. And nobody really knew what the reason for this was. Was it a vascular effect? Was it a neurological effect? Well, actually, this is a study from Singapore. 30 patients with type 2 diabetes randomized to fenofibrate just for 30 days. And look what happens. As you would expect, there's a reduction in the triglycerides, no effect on total cholesterol, HDL, LDL. However, corneal confocal microscopy shows a significant improvement in corneal nerve fiber density, literally within 30 days. So again, fenofibrate appears to be regenerating nerves. If we then look at painful neuropathy, of course, this troubles 21% of people in Caucasian studies, but in fact, in this region, we showed the prevalence was close to 40%. So how can we treat this? Well, the best study to date appears to be the Option DM study, which essentially looked at all the evidence-based treatments that we have, which are essentially tricyclic, amitriptyline, duloxetine, or pregabalin. And the bottom line is that you have an impact of all three medications by around 50%, 50% efficacy of if you had an NRS greater than 3. So essentially, all three medications appear to work equally. And you can see this here. So, and also, not only as monotherapy, but if you combine medications, you get a better effect. But overall, it doesn't matter what combination you use or which one you start first, overall, there is about a 50% reduction in overall pain score. And as an alternative, and it's something that I use in my clinic actually, we have shown previously that giving vitamin D actually probably has an equivalent effect. There's about a 50% reduction in pain scores with giving D3, vitamin D3, followed up over 20 weeks. You can see improvement in total McGill pain score, the pain score, and positive symptoms on the DM4, highly significant reduction. Interestingly, the baseline level of vitamin D in these patients was actually already what most people would say is very good, 31 nanograms. And yet, when you gave 600,000 international units of vitamin D, D3, it improved to 46 nanograms, and you got a reduction in pain scores. What about diabetic retinopathy? Well, for diabetic retinopathy, really the ACCORD study is very instructive in that it looked at the effect of glycemic control, dyslipidemia with fenofibrate, and blood pressure reduction. And what it showed is that if you can get HbA1c down from between 7 to 7.9% to less than 6%, you can reduce retinopathy progression by about 33%. However, if you give fenofibrate, you get a 40% reduction. And surprisingly, even though in the past we used to think that ACE inhibitor therapy was good for diabetic retinopathy, actually in that particular study, they did not show an impact. Coming back to fenofibrate, 200 milligrams, in the field study, there was a significant effect over 5 years on macular edema, proliferative retinopathy, and all retinopathy. So there is a significant reduction by around 30% in each of these measures of diabetic retinopathy. And on the basis of that, in fact, in Australia, fenofibrate now has a licensed approval for diabetic retinopathy. And indeed, there is now a large, I would say, insurance-based study from the USA, which has shown that fenofibrate does indeed have an effect on the progression of vision-threatening diabetic retinopathy. So this was a large study comparing 5,835 people with type 2 diabetes who were treated with fenofibrate compared to about 150,000 who weren't. And essentially, HbA1c, you can see, was pretty good, 7.3 and 7.5%. And, 87% and 96% had hyperlipidemia. What did they show? Well, they showed essentially that the vision-threatening diabetic retinopathy was significantly reduced in those on fenofibrate by about 8%. Proliferative diabetic retinopathy was again reduced actually by about 24% in multivariate analysis. But macular edema actually wasn't significantly different. Diabetic nephropathy, we all know that there are multiple drugs that we use for blood pressure reduction, but really the ACE inhibitors and angiotensin receptor blockers are the ones that have really shown benefit for diabetic kidney disease. But what do you do after you've got a patient on an ACE inhibitor or angiotensin receptor blocker and their proteinuria still continues? Well, you can actually use vitamin D. This is a study published over nearly 14 years ago, which shows that the addition of pyracalcitol, which is activated vitamin D, significantly reduces urine albumin-creatinine ratio by around 15 to 20%. And it also reduces systolic blood pressure. What happens when you've got an ACE inhibitor or angiotensin receptor blocker and vitamin D on board? An adequate blood pressure control, but proteinuria continues. Well, the latest data suggests that GLP-1 receptor agonist, particularly semaglutide, has a very good effect. So this is the FLOW trial published in the New England Journal of Medicine in May. Essentially shows that if you are on semaglutide, you have an EGFR, actually you can see, of 46. Glycosylated hemoglobin, pretty good, 7.8. Body weight, pretty good, 89 kilograms. 15% were on an SGLT2 inhibitor in the background. The rest were on either an ACE inhibitor or angiotensin receptor blocker. So with the addition of semaglutide, what happens? Well, you get a further reduction in HbA1c of 0.81%, reduction in weight of about 4 kilograms. But when you look at the primary endpoint, which is kidney failure from dialysis, transplantation, an EGFR less than 15, remember, going from an EGFR of 46, greater than a 50% reduction in EGFR or kidney-related or CV death, there is a significant reduction of about 34% in the semaglutide arm compared to the placebo arm. And if you look at the EGFR slope, you can see it doesn't completely flatten it out, but nevertheless, it slows down progressive reduction in EGFR. And also has an improvement, significant improvement, about 29% on death from cardiovascular cause if you're on semaglutide. And furthermore, when they looked at people who were also on an SGLT2 inhibitor, what you found is that if you weren't on an SGLT2 inhibitor, you really got a beneficial effect of semaglutide. But if you were on an SGLT2 inhibitor, the addition of semaglutide didn't seem to have that much of an effect. So what happens next? Well, we all know the SGLT2 inhibitors, and there are multiple trials that have shown this, have an impact. So whether it's empagliflozin, which will reduce your incident or worsening nephropathy and also flatten out the GFR. Canagliflozin in the Credence study, again, did the same, primary composite outcome, and also on the EGFR, or dapagliflozin. They all have a positive impact on renal outcomes, which is why now the American Diabetes Association, ESD, will all recommend the use of SGLT2 inhibitors, particularly in people with diabetic renal disease. So what next after all this? Well, actually, the new kid on the block is finerenone, which is a non-steroidal, highly selective mineralocorticoid receptor antagonist. So we know that spironolactone actually has a good beneficial effect, but finerenone now has evidence based in large clinical trials showing an impact. And we believe that this impact is because, you know, the other medications, they have obviously, they reduce glucose, they reduce oxidative stress, but we believe that inflammation and fibrosis is key to diabetic nephropathy. And that's where finerenone has an impact. And in the Fidelio diabetic kidney disease study, you saw a reduction in urine albumin creatinine ratio by about 30%, 30 to 40% across 36 months after randomization. And this was on top of maximal ACE angiotensin receptor blocker therapy. So further reducing microalbuminuria or proteinuria. And time to kidney failure, sustained greater than 40% decrease in EGFR from baseline or renal death, primary outcome reduced by 18%. So that again showing that finerenone has an additional benefit, and the number needed to treat after 3 years was 29. So in terms of guidelines, what we have now in terms of diabetic nephropathy, or what we had, are 3 distinctly different classes of drugs. So we start with the renin-angiotensin axis. So you've got the ACE inhibitors and the ARBs, which clearly is a major pillar of improvement in terms of diabetic nephropathy. More recently, we've shown that the SGLT2 inhibitors and GLP-1 receptor agonists now have an important role to play. And most recently, there is now data to suggest that finerenone is also important, and in fact, it's been added to the ADA and the ESC guidelines for treatment of diabetic nephropathy. Thank you.
Thank you very much, Professor Malik, for this updated, informative, and comprehensive lecture. Actually, several updates and new aspects and perspectives of some of the already present drugs and some future medications. I don't think مش معانا مش كده دكتور؟ اوكي. لو في اي اسئله ممكن احنا نناقشها لو عندنا وقت لسؤالين، مش كده دكتور ايمان؟ مين عايز يسال في ال اتفضلي بيه. بشكرك قوي، انا فعلا this is very impressive data عن فيتامين دي. والحقيقه ساعات بحس احنا شعب طيب قوي والناس كلها عماله تبلبع فيتامين دي، صح؟ لكن له فاسكولار بنفيتس غير عاديه. مش كده بقول احنا شعب طيب. فيتامين دي، وقد ساعات ان احنا بنحس بايه؟ ان هو طالع موضه وليه الناس كلها عماله اتس نوت لايك ذات ات اول. كل الداتا الاميرجنج بتؤكد ان في فاسكولار بنفيتس في فيتامين دي نيرف وايز اند كيدني وايز. ده طبعا غير السكليتال افكتس، غير الافكت على الاميونيتي، غير الافكت على improvement of insulin resistance and parameters of glycemic control. لكن هي الدوز اللي قالها فعلا دي جديده عليا. ده 600,000 international units. ده نوع من الاستادي، انت بتجيب volunteers وبتمضيه consent to do that. لكن طبعا مش standard of care ان احنا ندي such a very high dose. الستاندرد دوز بتاعتنا بندي من 5000 ل 10,000 units per day oral او 50,000 unit per week. لكن guided by 25 hydroxy vitamin D assessment. يعني ما نقدرش ان حد يجي ونديله الجرعات دي كده ونمشي عليها forever blindly. لكن فعلا دي فيري هاي دوز. عايز اقول دي حاجه اسمها ترايل، حاجه اسمها ثيرابيوتيك انترفنشن على حد ماضي كونسنت وليس ستاندرد اوف كير. اتفضلي بيه.
1000 وحده انترناشونال بتتعاطى لودنج دوز 200,000 وحده امبول كل اسبوعين. في خلال ال 15 يوم دول بيكون واخد كل اسبوعين 200,000 وحده. يعني هو ما ذكرش ان هم كلهم بيتاخدوا وانس.
ما انا
لا، هو مكتوب انتراماسكولار، فدي بتبقى لودنج دوز 200,000 كل اسبوعين. ال 600,000 وحده دول وبتكب العين بيمشي على الاورال.
بشكر حضرتك جدا على الايضاح. لكن الجايد لاينز بتاعت الاندوكراين سوسايتي قالت ان فيتامين دي ريبليسمنت should be oral except لو في evidence of significant malabsorption of vitamin D. يعني برضو بتعجب قوي من اللي هو بيجوا على طول الانجكتبل فيتامين دي. It should be oral on daily basis or weekly basis. If your patient مثلا compliance wise عادي كل يوم جمعة ياخد 50,000 oral فيتامين دي you can do that. لو عنده بقى significant malabsorption، حد عامل bariatric surgery أو في evidence that he cannot benefit from oral vitamin D, it's a justification of intramuscular vitamin D. عشان كده بقول لحضراتكم يعني هو الانجكتابل فورم in such a high dose مش القاعدة، هو الاستثناء. الاورال فورم هي القاعدة بالنسبة للفيتامين دي ريبليسمنت. أي أسئلة أخرى؟ Okay, thank you very much. By this I'm closing the session.